The first day I worked solo as a PA ever, so I've always worked in neurology. The first day I worked solo, they needed someone to supervise the DBS clinic. And that was my first day working alone. Of course, I had no idea what was going on. But it was really impressive. I was to see folks come, turned off and then turned on, and to see what DBS could do, it really was kind of a great first day. So I've been working in Parkinson's ever since then. So what I wanted to talk about today was sort of looking at I don't want to say the lifespan of MS or Parkinson's, but what we can expect. I think what a lot of people are very familiar with Parkinson's, or what the symptoms that get shared a lot, or what we really see early on in Parkinson's, and what's maybe we don't have as much education about, is what to expect and what things look like as Parkinson's advances. And you all know appointments can be fairly short. We want you to know things to be looking out for. They may never happen, but things to be looking out for so that you know to bring those up with your provider. So having a sense of what the landscape can look like, I think, is really helpful, so that we can address those symptoms as they arise, because a lot of the things that can happen with advancing Parkinson's are not really obvious. They may involve parts of your neurologic system that are not as readily apparent as, is your hand shaking or can you walk normally? And so I want to talk about some of those things so that we can be aware of them. The caveat that I want to give, though, is that if you look at the platter of options that can happen with Parkinson's, it can be incredibly overwhelming, because there are so many symptoms that can happen with Parkinson's over time. No one gets all of them. And so the important thing to look at is what could happen, so that I can be prepared, not necessarily this is what my life will look like in 15 years with all of these problems, because that can be incredibly overwhelming. One person with Parkinson's is one person with Parkinson's, and so not everyone gets every symptom, and not everyone gets every symptom to the same degree. And so because of that, the point of this is not to say, oh my gosh, everything is going to look terrible. The point of this is to say, let's keep an eye out for things so we can address them if they arise. Rather than 15 years down the road, there's a greater problem, and then we're kind of dealing with the fallout. So. And I am not a tech expert. Okay, now it will move. There we go. All right, so I wanted to have a couple different people to look at. So I've just created some stories of a couple different people living with Parkinson's. So the first one is Alice. So initially, Alice made an appointment with her family doctor because she noticed some changes in her walking. She was tripping over cracks in the sidewalk. She felt like her balance was off. She was feeling stiffer, and she was worried that she would eventually start falling. And because of this, she was using a cane for stability. Her family doctor didn't really know what was going on, but sent her to neurology to be evaluated because of the balance problems. And when she was evaluated by a neurologist, she was found to have shuffling gait, reduced arm swing, and increased muscle tone, which we call rigidity. And with that, she was diagnosed with Parkinson's disease. And then here's another person. So this is Danny. This is a scenario I hear about all the time. So Danny and his wife had been arguing because she said he had a tremor and he said he didn't. The tremor always happened when he was watching TV, and he was not aware that it was going on. And if he tried to pay attention to it, it would stop. Over time, though, he became more aware of the tremor. It became more persistent. His father had Parkinson's, and so he became worried that he also had it as well. When he was seen by a neurologist, they confirmed that his tremor was consistent with Parkinson's, and they found some additional symptoms. So he also had lost his sense of smell, and his wife commented that he had a tendency to yell in his sleep when he was dreaming, which are also Parkinson's symptoms. So two very different presentations, and we see this a lot. The folks that have tremor get diagnosed a lot faster, typically because the family notices it or the primary care provider notices it. Oftentimes folks that don't have tremor, that can take a little bit longer to get diagnosed. So early symptoms of Parkinson's, you may have come in with some of these when you were originally diagnosed with Parkinson's. So you can see at this point, oftentimes the list of motor symptoms, which are the obvious things, tend to be longer than the non-motor symptoms. So oftentimes people come in, they may or may not have a rest tremor. They oftentimes do, but not always. Typically, it's just on one side of the body or the other. So if any of you have tremor, it probably started on one side. It may now be on both sides. Increased muscle tone, which we call rigidity. Sometimes people feel really stiff, or maybe they're feeling really weak, or they might notice that their fine motor coordination is impaired because they can't move their hands as well. Movement also tends to be slow and small. So you might have noticed changes in your handwriting. You might have noticed that you had difficulty taking larger steps, that your steps tended to be small, or someone around you might have commented on that to you. Gait tends to change, so people will start shuffling. Oftentimes they will just notice initially that maybe you're tripping over cracks in the sidewalk a little bit more, or you might hear your feet scuffing on the ground a little bit more. And then oftentimes folks will notice that they have decreased arm swing, typically if you have a tremor on the same side that the tremor is happening on. And then mass facies. So the longer people have Parkinson's, the more they tend to not have a lot of facial expression. And I know this can be really frustrating for people living with Parkinson's because it can look like you're not interested or engaged in what's going on when that is completely untrue. It's just that your face isn't spontaneously moving as much. So when people have Parkinson's, a lot of us, and I do this all the time, we use our hands and we move around a lot and we have big facial expressions. And so we're just kind of constantly like fidgeting and moving in our body. People with Parkinson's don't tend to move any more than they absolutely have to. And that's not a choice, an intentional choice. It's just what happens. So someone with Parkinson's will tend to sit very still. If they're not talking, their face probably isn't moving very much. If they are talking, they might just be moving the lower half of their face rather than the upper part of their face. So they tend to get this sort of blank stare look, which has absolutely nothing to do with their emotional state or how engaged you might be in the conversation at hand. But some people can misconstrue it as that, and I know that that can be really frustrating for people living with Parkinson's. But the two are fully not connected. The non-motor symptoms, so other things, and these can actually predate the motor symptoms. So oftentimes 10 plus years before the tremor starts or before the shuffling starts, people will start getting REM sleep behavior, which is the yelling in your sleep, the thrashing around in your sleep while you're dreaming. Oftentimes it's chase type dreams, and so people, or fight type dreams, and so people may flail their arms and smack their bed partner or knock something off the bedside table. This typically is much more bothersome to bed partners than it is to the person having the Parkinson's, unless they hurt themselves. Insomnia or other sleep disorders. So lots of reasons to have insomnia, but Parkinson's is one of them. And sometimes people will say, you guys may have noticed this perhaps, that your sleep started to deteriorate 4, 5, 6 years before the other symptoms of the Parkinson's set in. Oftentimes people with Parkinson's have fully lost their sense of smell or have a really terrible sense of smell. And then constipation is a biggie. And oftentimes that will, again, many reasons to have constipation, but Parkinson's is one of them, and it can predate the motor symptoms by quite a while. We think the process of Parkinson's probably starts about 10 years before it becomes obvious to us most of the time. And so these other non-motor symptoms are oftentimes the things brewing behind the surface that in retrospect we can recognize that we may not have recognized before. So we're going to come back to this diagram again later, but we're going to look at this first little bit here. So early on, for most people, Parkinson's is relatively easy to manage. And by that, I do not mean there aren't struggles in your life or that everything goes back to normal. I don't mean that. But in terms of, if we look at medication, does it do what we want it to do? And does it cause us problems? If we look at this diagram here on the early stage side, that green zone is where we want to be. So essentially, if we're keeping your dopamine levels inside that green zone, your body's doing relatively well. If we get, maybe it'll come back. If your dopamine levels go above that green zone into the blue zone, you can start getting side effects. You can start getting other problems. If your dopamine levels go below the green zone into the pink zone, then you start feeling really off and slow. And that's oftentimes how people feel when they're first diagnosed, because their dopamine levels have dropped and we're not supplementing you with anything yet. And so people feel slow and stiff and they have tremor. And then once we get medications on board, things get better because we're raising those dopamine levels back up again. But you can see that it's not perfectly steady. So those levels go up and down each dose of medication that you take. And so most people with Parkinson's are treated with a single medication initially. And oftentimes that medication is dosed several times per day. 3 times is pretty typical. Some people might start with twice a day, but 3 times is pretty typical. And so every time you take that dose, your level is going to go up and then your level is going to come back down. But as long as you're staying inside that green zone, you may not notice too much difference. You may feel pretty stable throughout. So with early Parkinson's, in a lot of people, we can achieve that state where they say throughout the day, they're doing pretty good. They don't notice themselves going up and down in terms of their symptoms. They feel pretty stable. And that's what we're aiming for as long as we can. And early on, it's easier. So typically, I imagine for most of you, this is approximately where you started. So typically for early Parkinson's, our medications are, you're on one medication and it's dosed typically 3 times a day, but that may be different person to person. Generally, motor control is fairly stable throughout the day. So you take your medicine in the morning, it helps with your stiffness, it helps with your tremor, you're able to walk better. And throughout the day, that doesn't change a whole lot. That's pretty stable throughout the day. That doesn't mean you feel 100% normal all day long, but you're pretty stable throughout the day in terms of your symptom control. Physical therapy is recommended throughout Parkinson's. So a lot of my patients, some people love people are very split. They either love physical therapy or they hate physical therapy. It seems to go one way or the other. For those that love physical therapy, great, because it's your best friend in Parkinson's. For those that don't, we have to do it. So the point of physical therapy is to try to help retrain your brain how to move normally. So your Parkinson's brain is telling you to move really slow and really small. And if you're not thinking about your movement, you will revert to moving slow and small because that's what your brain is telling you to do. What physical therapy does is try to reteach you what normal movement looks like so that if you're paying attention to how you're moving, you can make yourself walk bigger and you can make yourself walk faster, or you can make yourself write larger, or you can have bigger movements. That tends to kind of revert back to the norm of being slow and small if you're not paying attention. But if the more you exercise, the more you do therapy, the more that can help your brain on its own start moving bigger and faster. So physical therapy is super important. It's our best tool for balance problems. No question, absolutely the best thing we can do for balance issues. And so it's really great to get in with therapists early on to get a baseline. And they may say everything is grand, keep doing what you're doing. But then you develop a relationship with a physical therapist. And then when you do need them, they're in your back pocket and you can get back in to see them. Physical therapy with Parkinson's is not the same as physical therapy for other things. So we all like when we sprain our ankle and we go see the therapist and we graduate 6 weeks later and we're done and we don't have to deal with it anymore. That is unfortunately not the reality of physical therapy with Parkinson's. It's an ongoing process. That doesn't mean you have to see the therapist every day for every week for the rest of your life. But it means that you go in, you get your therapy, maybe for 2 or 3 months. Then you go home and do your exercises at home consistently. And maybe a year later, you need to go back in for a refresh and to get some new exercises because things have changed in your life and things have changed with your Parkinson's. So it doesn't mean you have to be seeing a therapist constantly. It just means it works best as an ongoing tool throughout your Parkinson's. I also tell people as well, people say, well, what can I do other than medication to treat my Parkinson's? Medication is incredibly important, but equally as important is regular, consistent exercise. They do very different things, and one does not do the same, one does not cover for the other. So they are both really important. Getting regular exercise also helps keep you in good shape. It helps with your balance. If your body is in good shape, you have good core strength, you're going to be able to cope with the problems that come with Parkinson's better. If you're deconditioned and you're weak, then the symptoms that come with Parkinson's are going to affect you a lot more quickly and are going to make you a lot more unsafe more quickly. So if your body is in a good position to cope with the Parkinson's, you do better for longer. I have patients that are regular exercisers that have been bikers and skiers and everything their entire lives and just keep that up for as long as they can once they're diagnosed. And sometimes their medications stay incredibly stable for years because of the benefits of exercise for them. That the exercise is really helping train their brain to move faster and bigger. It's helping keep that stiffness at bay. And so exercise is a really important and excellent supplement. What I don't want to suggest though is that you have to be out skiing for this to work. So going for a walk or getting on a recumbent bike if a walk is unsafe, those are all excellent forms of exercise and they do similar things. So getting out and moving your body is really important as often as possible. So 4 or 5 times a week if possible. Okay, so for the first several years of Parkinson's, we have hopefully relatively stable control. We may need to increase medication dosing, but we're able to maintain that relatively stable control. And then things progress over time. So we're gonna check back in with Alice here. So Alice's initial symptoms were shuffling gait and rigidity. She didn't have that tremor that everyone thinks you have to have for Parkinson's. After starting on the medication, she was on carbidopa-levodopa, which is what most people get started on. She initially felt much safer. Her coordination and walking improved. She didn't have to use her cane for a while. With physical therapy, she was able to learn how to take bigger steps and her balance improved. Over time, she required increasing doses of medication to maintain control of her stiffness. She also started to notice that if she didn't take her medication on time, she would have worsening of symptoms. And it no longer got her to her next dose before it started wearing off. She started having some problems with swallowing liquids and a hard time communicating with people over the phone because her speech was getting softer. She developed constipation, which she was able to control fairly well if she stayed on top of it. And she started to see animals in her house that she knew were not real. Okay, and we have Danny. So over the next year, Danny's tremor worsened and he developed more stiffness on the right side of his body. He started to shuffle more with his right foot. So most of you probably have a side with your Parkinson's that everything is worse on, right? Everything is worse on, it might be present on both sides, but it's all worse on one side. And that is typically the case for most people. So everything is getting worse on his right side. He started to shuffle more with his right foot. He shuffled less on days that he exercised, but it was still a problem. Sometimes he would freeze in doorways and not be able to move his feet. His REM sleep behavior, so that yelling in his sleep, got worse. He began to act out his dreams, and he punched a wall and accidentally hit his wife in his sleep. He began to feel lightheaded and faint at the end of his workouts. He also had a few episodes of passing out when he got up first thing in the morning. He had to increase his medication dosing frequency to 5 times a day to stay on top of his symptoms, but this made his lightheadedness worse. At the end of the day, when his medication was working best, he developed restless movement of his head and his torso. So this restless movement, this is the video we were just fighting over for the last 20 minutes that we're not going to show. Do all of you know what dyskinesia looks like? I can kind of demonstrate, but if you've seen Michael J. Fox, we're going to skip the video. If you've seen videos of Michael J. Fox, he has dyskinesia. So he's got lots of movements, but that is the most obvious movement that he has. So it's just sort of this like restless movement like this. The reason I wanted to show the video, which we can't do, but is to be aware of what it looks like. So oftentimes dyskinesia is pretty subtle initially. It can just be kind of like a little kind of twitching movement like this. It could be an arm or a leg. It oftentimes is the opposite side of the body from where the Parkinson's is the worst. So if your right side is the worst with your Parkinson's, oftentimes the left side is the worst for your dyskinesia, most of the time. It can be really anywhere in the body. Head and neck is pretty common, torso is pretty common, or sometimes it's in the extremities as well. Legs oftentimes less common than arms, but it can be any of them. It can be your whole body. Dyskinesia is also frequently far more bothersome to your care partner than it is to the person who has Parkinson's, which is important to remember. It looks incredibly uncomfortable. So if you look at a video of Michael J. Fox, and I'm not making fun of him, but he's doing like this all over the place, right? And you go, why would you have your medications dosed so high that you're moving that much? And it's because he feels better that way than he does when his medications are lower. So most people with Parkinson's would rather have more of that extra movement and less stiffness if those are their options. Most people actually aren't super bothered by the dyskinesia unless it gets out of control and it's tiring them out, or it's causing them to not be able to sit comfortably in a chair, or it's throwing them totally off balance when they're walking. Those would all be problems with dyskinesia. A lot of people, when it's mild, don't even notice that it's happening, which seems really strange to someone watching it because we're all very aware of it. But the body just doesn't register the movement, oddly enough. So you can actually be kind of moderately dyskinetic and have no idea that you're moving. I simply say that because oftentimes care partners, or I'll be like, oh my gosh, that looks so bad. And my patients will say, no, it's fine. It's not bothering me at all. And our ultimate goal with Parkinson's is to have the person living with Parkinson's feeling as good as they absolutely can. So if they are more comfortable with dyskinesia than without, I'm okay with that, right? To a point. But oftentimes, as people as loved ones of someone living with Parkinson's, or as a care provider, we say like, I want to fix that thing for you because it looks so uncomfortable, and it may not actually be bothering those of you living with Parkinson's. So I say that simply because I think that's easy for us to forget. So motor symptoms of advancing Parkinson's. So the stiffness tends to get worse. This is true in most people with Parkinson's. Even if it was tremor predominant initially, where the tremor was the main symptom that you had, the stiffness tends to catch up. And it can spread to the other side as well. So if it started off just on your left side, eventually it tends to spread to both, even if that left side stays worse. People get worsening of bradykinesia, which is the slowness and smallness of movement. Tremor sometimes worsens, actually sometimes gets better. It depends. So the stiffer people become, sometimes the tremor actually calms down. So that can go either way. The shuffling of gait worsens, and people can have freezing. So to kind of demonstrate what freezing looks like, if you guys haven't experienced it, it oftentimes happens in narrow spaces. So going through a doorway, in a narrow hallway, bathrooms are the worst. Or it can happen with changes of floor patterns. So if you're going from linoleum to carpet or something like that, or you're going from just even a change from like a checker block pattern to a striped pattern, something like that can cause people to freeze up. People tend to have really bad issues with freezing. Actually, freezing tends to be much better when you're outside. So you tend to think of wide open spaces as being a worse fall risk a lot of the time because there's like nothing to grab onto. But for freezing, it's typically way better. So those tight spaces actually cause more issues for freezing. So freezing tends to look like someone's trying to walk and then their feet get held up and they kind of get this sort of thing going, and then they eventually get themselves moving again. Sometimes it's right with starting walking, so you stand up, you kind of get your bearings, and then you can't get moving. Other times it happens when you're trying to turn or when you're trying to transition through those tight spaces. The absolute worst thing to do if you have that freezing is, and as a care partner of someone that has freezing, is to try to push them through it. The more stressed you get, the absolute worse it becomes. So the best thing you can do if that happens, or if you're a care partner of someone, is to calm the situation. Have someone take a break, reset, try again, provide stability if they need support so they don't fall, but not to say, move your right foot, move your right foot, move your right foot. We want to do that because we see the situation looks unsafe and we want to get through it, and you're trying to help. But anything that increases stress actually tends to make this worse. So the more you can take a deep breath, realize we're not in a rush, calm down. Even though it's frustrating, oftentimes it will stop and you can actually get yourself moving better again. So that masked faces, that flat facial expression tends to become more pronounced over time. And then we tend to get motor fluctuations, which we'll talk more about in a second. You see this list of motor symptoms has gotten much longer. Non-motor symptoms has gotten much longer. And these are a lot of the things that I want to talk about more so that we can be prepared for them. So here we go. So that REM sleep behavior, again, we have one of our patients, Danny, was having more of that. REM sleep behavior is something that early on, if it's not bothering anyone, I leave it alone. As soon as it starts causing problems, though, it actually is treatable for most people, and we do want to treat it. I don't want my patients, bed partners, to feel unsafe or not be able to get any sleep. If people feel more comfortable in separate beds, that's fully fine. But if that's not your preferred way of addressing this, there are medications that can treat this. So I let folks kind of tell me when they're at the point where they want to do that. But this is something that I really pay attention to care partners about, because the person having Parkinson's oftentimes is fully unaware that this is happening. Because there's sense of smell still tends to be gone. Constipation tends to worsen. Increased drooling, and that's due to decreased swallowing. So it's not due to producing more saliva. That saliva just hangs out in your mouth longer because you're not swallowing as frequently. And so you tend to have more drooling because of that. People can develop swallowing problems. generally more with liquids rather than solids, although not 100% of the time. But that tends to be the pattern. So people will have difficulty swallowing their saliva will be the first things they tend to notice. They wake up at night, they feel like their saliva's all stuck in their throat and they're having difficulty swallowing it, or they're having difficulty swallowing their water, taking their pills with water. Orthostatic hypotension, we're going to talk more about this. This is happens to almost everyone with Parkinson's to some degree. It can be very mild, it can be very significant. But orthostatic hypotension is the tendency for your blood pressure to drop when you're standing. So your blood pressure could be normal when you're sitting, it could be high when you're sitting, it could be low, that's kind of irrelevant. But you stand up and the top number of your blood pressure drops 40 points. It could drop from being too high to still being too high, but if it drops quickly, that can make you feel incredibly lightheaded and incredibly dizzy. If you have low blood pressure to begin with, you're going to be way more susceptible to this because you don't have much room to drop before you start feeling really terrible. So this is, don't quote me on this number, but I think it's in the like 80 to 85% of people with Parkinson's develop this. It's really, really, really common. Mood changes. So a lot of people with Parkinson's develop depression and anxiety. That can be due to living with chronic illness, right? The Parkinson's changes your life over time. It's something that you have to deal with on a daily basis. There are things that are more difficult or more unsafe for you to do over time. And those things on their own, living with chronic illness, can lead to depression and anxiety. Also, the fact dopamine, which is the chemical we care about in Parkinson's, affects movement, but very much affects mood as well. And so what we can see sometimes as Parkinson's progresses, not only are we seeing more depression and anxiety in some people, but that it actually can start fluctuating too as those dopamine levels start going up and down more throughout the day. People may be fine-ish until their meds start wearing off, and then they start feeling like they're going to have a panic attack every time it happens. And that's something that we want to know about. So if you feel like I'm great until 30 minutes before my medication dose, and then I mentally or emotionally feel like I can't handle things, or I'm super panicky, or I'm super depressed, and then I take my medication and it kicks in and I feel okay again. Even though that pattern, some people will say, well, I know I'll be fine again in 30 minutes. Okay, but we also maybe can make that better. We might be able to even out your meds so you're not dealing with those dips as much. And those dips can affect motor symptom control, but they absolutely can affect mood too. So we want to know about that. Cognitive changes. So most people over time with Parkinson's will develop some cognitive impairment. That is not a guarantee of dementia. Some people with Parkinson's do end up getting dementia, but that is not a guarantee. But folks will start experiencing problems with memory, problems with attention, and they can have problems with executive functioning. That's a big word for planning, prioritizing, organizing. So being able to give someone like a 5-step set of directions and being able to get all those directions done in the right order, or you're planning for a trip and being able to coordinate, I need to call someone to take care of the dog, and I need to get this suitcase packed, and I need to make sure I didn't leave the front door open, and making sure all those boxes got ticked. That's part of executive functioning, and that type of task can become more difficult. It is common with Parkinson's to have increasing fatigue. That can be fatigue in and of itself, and that can be fatigue due to dealing with all of these other things. Hallucinations can occur, and we're going to talk more about those in a little bit. And then vision changes. This is one of the ones that I think is a little bit less well known. People can develop problems with double vision. And people can also have difficulty keeping their eyes open. So that they tend to have their eyes closed just fine, and they will eventually be able to open them, but it takes a lot of time and potentially a lot of effort. It's not because they're spasm closed. So there are other eye conditions. There's something called blepharospasm, but it's basically where you're getting spasming of your eyelids and they won't open. That can happen with Parkinson's, but that's not typically what happens. Typically, it's a muscle coordination issue. So just like you have impaired muscle coordination with your handwriting and with your walking, you can get impaired muscle coordination on how those muscles need to contract to keep your eyes open, eyelids open. It's a hard thing to treat, to be honest, but it is something that we want to be aware of, and that we want to be able to educate you guys about if it happens. And there are eye specialists up in Denver that can potentially help evaluate this a little bit more if it's something that we need to. Okay, so back to our diagram again. So if we're looking more into the the second and third box of this. So we said we wanted to stay in the green zone when it comes back. And we typically in early Parkinson's can stay in the green zone pretty well. Even if we're fluctuating, we're staying fairly well with our dopamine levels and our medication levels. We're staying pretty well in that green zone. We're doing fairly well. The longer we have Parkinson's and the more reliant people become on the medications, and this is not an addiction thing. This is because your body is producing less and less dopamine over time, and so you become more reliant on supplementing it with medications. So the more that happens over time, we start seeing that we're going into the blue zone a little bit, and we're going into the red zone a little bit. So we're having experiences where we're too medicated, despite our best efforts, and we're having periods of the day where we're under-medicated, despite our best efforts. And this poses a lot of challenges for managing Parkinson's. There are hopefully new delivery systems for levodopa on the way that will solve this problem in the fairly near future if everything goes through the FDA. So hopefully this big problem here in the next few years will be much less of a problem. But as of where things stand right now, you can see this person here, this proverbial person in this diagram is now taking their medication 5 times a day instead of 2 or 3 times a day based on the previous section. When those drugs go too high, so we're in this blue zone here, people tend to have more dyskinesia, so more of that restless movement. That is generally a symptom of medication levels being too high. That lightheadedness, that orthostatic hypotension also tends to be worse when medication levels are too high in most people. And then the low, so the red zone, you tend to be more stiff, you tend to have more trouble walking. A lot of the things that probably took you into being diagnosed with Parkinson's in the first place are going to become more pronounced when your medication levels are too low. And again, as I mentioned before, also we will see over time that a lot of the depression and anxiety can also worsen at that time when the medication levels are dropping. And then if we look at this last section here, you see it just becomes kind of more and more unreliable with time. And there's a lot of things that feed into that have to do both with your body and with the meds. So this is one of the things that I wanted to look at. So like practically, we can talk about Parkinson's and what Parkinson's does all day long, but practically I wanted to offer some suggestions about really good ways to prepare for your appointments with your Parkinson's provider. So whether you're seeing a general neurologist for your Parkinson's, whether you are seeing a movement disorder specialist for your Parkinson's, whether you're seeing both. I think these are, from my perspective, really good things to have to come into your appointment with initially. So we talked about a whole bunch of symptoms. So if we look back here, this is a whole bunch of things, and your appointment is probably 30 minutes long, maybe not even that long. This is a lot to go over. And we tend to, because we want to make sure we're not missing things, we tend to kind of start in one place and move to step 2 and move to step 3 and move to step 4. If you're primarily concerned with step 7, I don't want to not talk about that because that's at the bottom of my list. So I want to know going into your appointment, what are you most concerned about at that appointment? So that I start in the place that is most relevant for you. So if you come in with a list and you tell me, I'm passing out, I've fallen 4 times and I can't swallow my pills, we may spend the entire appointment just talking about those things and not talk about the other stuff on that list. So I want to know where to start. I also personally love to have a written down list that someone can just hand me and I can just look at, because oftentimes I can address multiple symptoms at the same time because I see all those things and I go, oh, I know what the problem is. It's actually one problem causing all of those other things. If we address them all as separate issues, sometimes we don't see the big picture. So I actually, folks just come in with a list and hand it to me. I love that. It is very, very helpful to me to have folks come in and having had them paid attention to when their symptoms happen. So, and I ask these questions anytime someone tells me, oh, I'm shaking more, I'm going to go through this whole list of questions. And if folks have paid attention, it's really helpful. So when I meant this with this diagram with these motor fluctuations, the longer you have Parkinson's and the less time you're spending in the ideal zone and the more time you're spending above or below the ideal zone, sometimes there are symptoms that can happen at any of those places. And so if you can come in and tell me, generally this always happens an hour before I'm due for my next dose, or it starts happening 30 minutes after I take my medication, or it's always first thing in the morning, or it's always in the middle of the night. If you can give me a sense of time of day, if there's a pattern, and there may not always be, but if there's a pattern, it's generally this time of day, or it's generally this time of day, or it's always, every time I take my medication, it's always happening at about this time. That helps me know, are we looking at too much medication, too little medication? Is it unrelated to your medication? And so it helps me know what we need to attack in terms of trying to change something. Again, this mood thing is a good example. So if overall you're experiencing a lot of anxiety all day long, it wakes you up in the middle of the night, it's a constant thing that's affecting your life, we may address that with a medication to try to help decrease anxiety that is not a Parkinson's medication. If you're telling me that I get anxious every time my meds are wearing off consistently, then I may actually not start an anxiety medicine, but may try to even out your medication dosing so we're not getting that up and down all throughout the day. So I want to try to target your symptoms as specifically as possible and keep you on as few medications as possible. I don't want to throw an anti-anxiety medicine at everyone having anxiety if that's not what they need. So the more you can pay attention to when the symptoms are happening, the more we can hone in on what is causing them. And that is really, really, really helpful. There may be other things that trigger them too. So it might be eating a meal may cause a problem. It could be exercising causes a problem. So those are other kind of daytime events that could have an impact. Knowing when and how you take your medications. So as some of you probably know, Parkinson's medication dosing can become quite complex. People can be on sometimes dosing 5-6 times a day. Sometimes not all those doses are the same. We try to keep it as consistent as possible, but sometimes it doesn't. Sometimes there's reasons to not do that. And so making sure that you know how you're taking your medicines and that you know what you're taking with each dose is really important for us. And if there's a reason that you've changed that, please let us know. So if I assume you're taking what's prescribed and you aren't taking one of those doses because it was causing you an issue, that's probably just fine. We just need to know. So making sure that you know what you're taking and when you're taking it is very important. Bringing in an accurate medication list that has medicines from your other providers, because we don't necessarily get those updated in our system, and we want to make sure that we can take those into account if you're having new concerns, and that we don't prescribe things that are dangerous for you. So we want to always have an updated list, particularly if anything's changed since your last appointment. Anytime we're looking at the effect of your medications, again, we're going to look at how long is your drug working. So every patient, I'm going to say, okay, you take your pill in the morning. How long does it take for it to kick in? And they'll say, it's taking 2 hours to start working. Okay, that's not great. And then I say, well, how long does it last? And they say, well, after it starts working, it only lasts for an hour. And then I feel terrible again, right? This is a horrible drug scenario, but sometimes that's what's going on. So we want to have a general sense. Sometimes it's my first dose takes forever. I don't feel like I start moving well until after my second dose, but then I'm fine the rest of the day, right? So these are all patterns we want to know about. If you've noticed any side effects from your medication, and then we want to know if you have noticed whether separating your medications from your meals makes any difference. Some people, are way, way, way more sensitive to this than other people. So if you've noticed, and if you're taking medication 5 or 6 times a day, it kind of gets difficult to separate it from your meals at some point. And so some people will notice that if they take their medication with a meal, it doesn't seem like it does anything. But if they take it on an empty stomach, that it works a lot better. This is true for most people to some degree, but again, some people are way, way, way more sensitive to it. And we want to take that into account when we're planning your medication regimen to make it work the best for you. If you've developed any new movements, try to get a video of it if it doesn't happen all the time. So sometimes people will put a label on what they think is happening. So they'll call something a tremor, or they'll call something dyskinesia because they've heard that term and they've been asked about it a whole lot. So they assume this must be dyskinesia when it starts happening. If it's not something that's happening all the time, if you can get it on video, then we can actually see what's going on, as opposed to maybe using an incorrect label on something and actually treating it incorrectly. So if something happens constantly, don't worry about it. But if it's only happening at 5 o'clock in the evening when you're not at your medical appointment, then getting a 15-second phone video of it really helps us out. And then check if you're having problems with lightheadedness or dizziness, check your blood pressure at home. So the blood pressure in the medical clinic may be accurate, may not be accurate. We know that a lot of people's blood pressure does go up when they're in the office, and there's a lot of reasons for that. It could be you just walked all the way from the parking lot and all the way up the stairs, and we got you back to the room right away, and you didn't have a chance for everything to calm down before we took your blood pressure. It could be you're worried about your appointment. There could be a lot of things going on. So knowing what your blood pressure typically looks like at home. Bonus points if you can do what we call orthostatic vitals, which is actually pretty easy to do. So if you can, if you're noticing that you're getting really lightheaded when you're up and about, if you can take a blood pressure when you're laying down and then stand up and take your blood pressure again a few minutes later and see what the difference is. That is really helpful because again, that blood pressure dropping problem can happen. You can have any resting blood pressure and it can still drop when you stand up. So if the only blood pressure readings we have is when you're sitting, it doesn't necessarily tell us a whole lot. And we can check this in the clinic, but it's good to have information at home too. So if you can do that, if you have an easy blood pressure cuff that you can use and you feel comfortable using and you can do that, that can be helpful. Don't feel the need to do it every day, but it can be helpful to have a couple of readings. And then if you're falling, if you can think back and think about what led to the falling. So we of course care if you injured yourself, but what we are looking at is how do we keep you from falling again, right? So if you fell and broke your wrist, the orthopedist is hopefully going to help you with that. We want to make sure you don't have to have an appointment with the orthopedist again. So we want to know what led to the fall. So any information that you can get about, I felt like I passed out, I tripped over my feet, I froze in a doorway, I got really dizzy, any information like that is really helpful for us trying to help work with you to figure out what led to the falling. Sometimes it's really obvious, sometimes it's not, but that is all very helpful. Okay, so over time with Parkinson's, generally people have to increase the frequency and dosing of their medications because they tend to wear off more quickly. Specific timing becomes more important. So the absolute best thing you can do for yourself with Parkinson's is get in a habit of taking your medication at the same time every day. Absolute best thing you can do for yourself. Early on in Parkinson's, it probably doesn't matter as much. So you could take it kind of when you get up, kind of around lunch, kind of around dinner. It's going to do the same thing. If you're an hour or two off, it doesn't make much of a difference. The longer you have Parkinson's, that is not true. And the more in a habit you are about taking it at consistent times and you develop a good strategy for helping yourself do that, the better you're going to cope with advancing Parkinson's. So I'm a huge fan, if you're at home most of the time, of alarmed pill boxes. I think they take all the guesswork out of taking your meds. And because you have to walk to your pill box to turn off the alarm, you're more likely to take your pill. I used to advise folks to just set alarms on their phone and then you just turn the alarm off and you don't go take your pill. So, and I would do the exact same thing. I put myself in this category. I would do the same thing. So I think alarmed pill boxes, you can just get them on Amazon. I think they're a really good strategy. And typically they can program up to like 5 or 6, 7 times a day. So they typically can accommodate the frequent dosing that we see with Parkinson's. And I think people that just look kind of little football shaped things, they just bring them with them in the car. They bring them with them on outings, you know, so they don't, even if you're out and about, I'm sure you can get smaller ones you could fit in a purse. So they can take that, you can take it with you as well. So I think that really helps because as much as we want our brains to rely on our brains to help us do things, it's just, if it works, great. If you're really consistent and you can stay on your meds and you don't need a reminder, fantastic. But most people, I think, including myself, would not be very good about doing that. So do something to help yourself so that you can move on with your life and don't have to constantly be checking to see what you're doing for your medication. Oftentimes we have to add additional medications as Parkinson's advances. So typically early on, in most cases, most people are started on carbidopa, levodopa, and that dose is gradually increased. And then as folks start developing side effects or having breakthrough symptoms, the medication isn't lasting long enough, we have to start adding other medications on board to try to smooth out the ups and down effects of that medication wearing off. And there's a whole lot of examples of this. We try to do as little as possible because we want you on as few medications as possible, but we oftentimes do have to add other medicines. One of the good or bad things about Parkinson's is that because medications in Parkinson's wear off really fast and you're having to take them multiple times a day, that's really annoying, we know, because you have to take it multiple times a day and you're getting this up and down effect. But it also means that if we try a new medication, we know really fast if it's going to help. And we know really fast if there's going to be a problem. And if there is a problem, you stop taking it and you're fine within a day or two. So the risk of trying a new medication is oftentimes a lot lower with Parkinson's. You know, if you try a medication that you've got to be on for 2 to 3 months before we know if it's doing anything, and you've got to suffer through all the side effects, and that's a lot of your life you're dedicating to that medication trial. When we're looking at Parkinson's, because these medicines act so fast, oftentimes within 5 to 7 days, we're going to know if this is a good thing or a bad thing for you. So, and if it does have problems, it's not going to take you 2, 3, 4 weeks for the side effects to wear off. You stop it and they're going to wear off very fast. So oftentimes the risk is a little bit lower. And if we try something and it doesn't work, oftentimes for the provider prescribing medication, that gives us just as much information as if it did work. It's frustrating, I know, on your end, but oftentimes the second trial will work better. So if you try something and it doesn't work, we say, aha, that told us something, let's try this instead. And oftentimes the second thing will work better. Physical therapy starts becoming even more important. Oftentimes folks will need speech therapy as well. And there's increasing need to use assisted devices. This is not failing. If you need to use a cane, use a cane. If you need to use a walker, use a walker. I would far rather see the folks that I work with able to be active, able to be safe, not falling, than seeing them fearful of falling or self-conscious about using a cane, and so they don't get up and move around all day because they feel so unstable. If you're walking with a walker or you're walking with a cane, you are still walking. And so I advise folks, if they feel like they need those things, to use them, because ultimately it's going to allow you to be more safe and more independent and more active, all of which is going to help improve your quality of life, improve your safety. So those are not we try to keep you doing as well without those things as long as possible. But when it gets to the point that you need them, I encourage folks to use them. Multitasking also gets to be more difficult. So because with Parkinson's, I have every time, I probably hear this 10 times a day. Folks tell me, I have folks walk down the hallway and their care partner says, they never walk that well. And we know that because we have wide open hallways and you are focusing on your walking. So you are going to absolutely walk the best you can walk when you are paying attention to your walking. And so when you are going about your daily life and you are doing other things while you're walking, your walking is going to tend to deteriorate. And then if you pay attention to how you're walking, you're going to start walking a little bit better again. So I tell folks living with Parkinson's that if there's something that is particularly tricky for them, like walking around their bathroom, for example, they tend to freeze up in their bathroom, is the worst place for them, to really try to not be multitasking while they're there. So, and for care partners as well, don't be trying to have conversations. Don't be giving the person with Parkinson's 10 tons of directions while they're trying to navigate that space. The more they can just focus on what they're doing and do that as well as they can, the more likely that their gait will be as normal as possible or their movement will be as safe as possible. So when folks you'd say they go on a 20-minute walk every day to exercise with their Parkinson's, I try to encourage them to really focus on their walking while they're doing that. So great to go and look at the fall leaves. That's wonderful. That's not the point of your Parkinson's walk. So the point of your Parkinson's walk is to focus on walking well, big steps, fast pace, safely, but to focus on moving the way you want to move. If you dedicate that time to doing that and then you want to walk another 10, 30 minutes and enjoy the leaves, great. That's good. But you really want to use that exercise time. You want to get the most bang for your buck. So what you don't want to be doing going on that walk is necessarily reinforcing bad walking habits, right? You want to try to reinforce good walking habits. Again, there's no way to do this all day long. There's going to be periods of the day where your walking is better than other periods. That's not failure. But the more you're focused on what you're doing, particularly in situations where they might be a little bit more precarious, the more likely your brain's going to be able to kick in to do the difficult thing better. Okay. So I just wanted to talk about a few of the non-motor symptoms, things that show up a lot or things that maybe people haven't heard about before. So this blood pressure issue, again, happens in almost everybody. Sometimes really early on, sometimes not. This is one of the big questions we look at when folks are falling, right? So were you aware that you fell or did you find yourself on the ground, right? Were you standing at the refrigerator and then you were on the ground and you don't know what happened in the middle? So you lost consciousness for a few seconds. Or did you tripped on the dog and you grabbed onto the stairwell and then you fell the other way, and you can tell me the whole story of what happened on the way down.
those are potentially different scenarios. So with this blood pressure issue, the most common feeling is the feeling we've all had if you jump up too quickly out of bed in the morning when you're dehydrated and you feel like you're going to pass out and you've got to grab onto something until you right yourself and you feel okay. That's the most common feeling, but it's not the only way that this can feel. So I have other people that tell me, you know what, I just don't feel good when I'm standing, and it's not that my legs are weak or that my back hurts. I just sort of feel out of it. And if I can sit down or lay down on the couch, not to take a nap, just to be horizontal, I feel better. And then, and it's not because I rested for 30 minutes. It's just because I sat down, I feel better. And then I get back up again, and pretty soon I feel out of it again. That can be a blood pressure problem. So other maybe less common ways that this can appear is that you feel like you have brain fog. People get super irritable. They get very fatigued if they're on their feet too long. So hydration is the piece of this we can't avoid. So there's lots of reasons why folks are dehydrated. Sometimes they have difficulty swallowing, and so they're concerned about that, so they don't drink very much. Sometimes there's other reasons, prostate problems or urinary urgency, other reasons why if they drink more water, they're gonna be in the bathroom all day long, and so they try to avoid that, so they don't drink very much water. As we get older as well, we also just lose our drive to drink. We aren't as thirsty, even if we need water. So we don't have that thing reminding us to drink water, even if we need to do it. So if our blood volume is low, if we're dehydrated and we don't have as much blood volume, this blood pressure problem is going to be way worse. So essentially what happens is if you stand up, your brain has to tell all the blood vessels in your body to constrict, to force blood to go up to your head, because gravity wants it to go to your feet. And if you don't have much blood, you can't do that. And so if you're dehydrated, this is going to be worse every time. So hydration is step one. If approved by your other providers, I'm not saying this is good for everyone, increasing salt. So if you don't have heart failure, if you don't have swelling in your ankles, if you don't have high blood pressure at baseline, salt is probably your friend, not your enemy. We've all been told salt is terrible, but salt is terrible in certain situations, not in all situations. Adding salt helps you hold on to water. That's why it's bad in certain situations. But if your blood pressure is dropping, that's also a good thing for you. So some people increasing salt is good. Compression stockings can be really helpful, just like athletic compression stockings up to your knees, because that provides some back pressure. So when all that blood wants to go down to your feet, that's some back pressure trying to help push it up towards your head a little bit better. So that can help. The cooler months are maybe the right time to try this. So folks, I tell folks this in July and they say, yeah, fat chance. But now that things are getting cooler, this might be a good time, if this is a problem that you have, to give this a try. There are medications that target this problem directly. So there are medications to increase your blood pressure that we can use. We're obviously not going to use that if you have high blood pressure to begin with, but in some people, those are good options. And there are other medications that can make this worse. So this is one of the reasons why we want to know if you've had any medicine changes, even if they seem fully unrelated. So maybe you saw your urologist because of prostate issues and he put you on a medication for your prostate. The vast majority of those can worsen this problem. And this may not be an option. I have a lot of patients that they cannot urinate if they don't take these medications. They absolutely have to. And so we have to try to deal with it a different way. But this is why we want to know what other things that you're taking. One of the difficult caveats of advancing Parkinson's is that the main medication for Parkinson's, carbidopa-levodopa, makes this problem worse. So this can be one of the limiting things. So people say, well, I'm getting a lot stiffer or my tremor is getting worse, but I also get lightheaded when my medication dose goes too high. And this can be an issue that we have to deal with. So that's where sometimes knowing that timing of when you're having symptoms can be helpful. Speech and swallow issues. So a lot of people, most people with Parkinson's, eventually their speech gets softer, sometimes a lot softer, sometimes a little bit. Typically this will show up first. Maybe folks might have a hard time understanding you on the phone where they can't see your lips moving and they don't have that extra context to look at. Sometimes people can also get slurred speech, so that their speech is not just soft, but they're also, because they're having a hard time coordinating their tongue, they're not forming their words quite as distinctly as well. Speech therapy is super, super helpful for this. Speech therapy also works with swallow. So there's this super cool test we can do called a barium swallow study, where they set you up with a real-time x-ray and they have you swallow things of different consistencies. So a pill, a cracker, liquid, pudding consistency, and they actually watch on the real-time x-ray, they watch it go down your throat. And they can see where there's a problem with your tongue coordination, if there's a problem kind of at the base of at the top of your throat here, they can see what the issue is. So it's a non-invasive test. It's really, really helpful. It's done in combination with the radiology department and then a speech therapist. And then that helps them get a really good look at where the problem is, if there's a problem, and how they can address their therapy. So that can be incredibly helpful. And sometimes it's just as much as them at that appointment just saying, hey, I think that problem would go away if you just repositioned your head a little bit when you were eating. And sometimes that's all that it takes. Other times they'll recommend further therapy. The thing with speech therapy though, that I tell folks is you absolutely have to be compliant with your exercises at home. So if you go to speech therapy and they release you and everything is great, and then 2 weeks later you quit doing your exercises, you will revert back to where you were before. So speech therapy can be incredibly helpful, but you have to stick with it outside of therapy. So that's my challenge for folks that are having to deal with that. And what I oftentimes recommend that folks do is it can get I feel the same way. So I go see a therapist, and every time you go, they give you like 3 more exercises, and you suddenly have this like packet that is overwhelming in size, right? And so I encourage folks to set an amount of time that seems whether it's physical therapy, speech therapy, set an amount of time that seems reasonable. So let's say 15, 20 minutes, that you can find 15, 20 minutes every morning to do your therapy exercises. Set a timer, start at the top of your packet, work your way through, get as far as you can go. The next day, start with where you left off, so that you set an amount of time that is not overwhelming to you, whatever that is. You make a habit out of doing it, but you don't look at this big set of tasks and get overwhelmed by how many tasks you have. When the alarm goes off, you can be done, regardless of how far you got. I think that can be a little bit more helpful with establishing a routine and establishing a habit, because no one likes doing therapy. I don't either. So getting it into your habit that you get it done after breakfast or whenever you do it, you get it done, you move on with your day, but that you're doing it consistently is really important. Another plug for not multitasking. And this is, I mean, in that comment, I say that more, it's really towards care providers. Oftentimes, if we're not experiencing the symptoms, we forget, right? So we're used to having dinner and having a conversation and doing all these things simultaneously and giving someone instructions and drawing their attention over here. And our brain is working fast enough to keep up with all those things. It can sometimes be easy to forget that the other person can't, and that can potentially pose safety risks. So I don't mean you can't have a conversation when having dinner, but maybe don't start it like right when someone takes a bite and they're having to worry about swallowing. Hallucinations. This is, I think, one of the scarier things that people see when they look at symptoms of Parkinson's. This does not mean you're going crazy. I've had patients ask me that. So I've said, they're just like, I see strings coming out of the wall. I don't know what is that? Typically, so when we think about hallucinations, we've all seen like horror movies or heard about people going through substance withdrawal or things like that, where they feel like, you know, they're being attacked by a horde of insects or things like that. That is not what Parkinson's hallucinations are like. So the vast majority of the time they are visual. I'm gonna say 90% of the time, don't quote me on that statistic, but in my experience, I would say that's about right. They can be auditory as well, so people can hear things that aren't there. Music is really common, that they'll hear like a song on repeat that isn't there. But most of the time they're visual. The types of things people describe to me, animals and people are really common. So I had a patient tell me once, I see 3 cats in my house. I know I only have 2. It's fine. You know, she didn't really care. She knew which one wasn't her cat, you know, so, or I had a lady tell me once that she would sit in her living room and watch her dining room furniture rearrange itself around her table. She was like, kind of weird, but fine. Sometimes people, it'll just be small things. They'll see splotches of color. The most common thing is, and we all have this happen occasionally, the whole like, I think I see something out of the corner of my eye, and then you turn around and it's not there. That is actually a hallucination. We all have this happen occasionally. With Parkinson's, it can happen a lot. So that is, and that's oftentimes one of the early ones that people describe. It's like, I'm not really hallucinating, but I have this like, I think I'm almost hallucinating, you know, and that's kind of the early thing. Early on with Parkinson's, most people are pretty aware that the things they're seeing are not real. So they know that rabbit does not belong in their house. They know that the child they're seeing in their backyard isn't there. If people have Parkinson's in combination with dementia, that insight can go away. So sometimes people are not aware that they're not real. And that is a point where we oftentimes do have to treat them. And we do have better treatments now than we had 5 or 6 years ago for treating hallucinations and Parkinson's. They're a lot safer than the medications we used to have. And they're really, the main medication that we use is actually targeted specifically for people with Parkinson's and hallucinations. So we do have options now, but we want to know, I always ask folks, or care partners, if they say, yeah, my loved one with Parkinson's is hallucinating, do they seem to be aware that it's real or not? The big thing about hallucinations, oftentimes the folks, a way to distinguish them, the people tell me is that, and I think this is true most of the time, if it's people, if they're seeing people, that if they're hallucinations, they don't talk back to them. Is what people pretty much tell me. So they'll see a crowd of people in their bedroom, but they won't speak to them. But most of the time, again, these are not scary situations. Early on, I don't tend to treat them. So if someone is very aware that they're having hallucinations, they're not very frequent, and they're not bothering them at all, I don't want to add medication to medication. If they start becoming frequent where they're just driving you crazy, even if you know they're real, but you'd rather not be seeing them, or if they start becoming problematic, then we absolutely have options of things that we can do to treat. This is another thing that tends to be worse with carbidopa-levodopa. So this is, as we get more advanced in Parkinson's, we're not always increasing meds, because we can start getting more problems with some of these other things. We have to try to find a little bit more of a not happy balance, but a little bit more of a balance where we have things where we're trying to get things at the best balance for you. And that might mean a little breakthrough of one thing or a little under treatment of another thing to prevent something worse from happening. Hallucinations tend to be worse in people that have vision problems for other reasons. So if you have poor vision to begin with, because you've got macular degeneration, or you had a stroke and you've got a big blind spot, the brain tends to fill in things you can't see very well with more exciting things. So you might have a coat laying on the floor and your brain tells you it's a puppy. So oftentimes people with poor vision will have hallucinations, but in the context of something actually being there, they just think it's something else. And there's a big fun, fancy word for that is unimportant, and I don't remember what it is, but that can happen. And then the last thing is cognitive impairment. So most people living with Parkinson's do develop some degree of cognitive impairment with time. This can develop into dementia, but it's not guaranteed to. It is definitely something we want to stay abreast of. So if you have noticed, either the person living with Parkinson's or care partner, if you've noticed that there seem to be more safety concerns, or you've missed 8 appointments, or you've lost your credit card 4 times, or things like that, we want to be aware of that so that we can keep an eye on things. My 500th plug for exercise is there is really good evidence that exercise helps with cognition. Absolutely, no question, outside of Parkinson's. This is fully apart from Parkinson's. When we look at studies of people who have really early stages of cognitive impairments, not dementia, but really early stages of memory impairment, and what seems to help keep that from progressing, exercise comes out #1 every single time. Which is nice, because this is something we can do, right? So when we're looking at a disease where there's a lot of things that seem to be outside of our control, this is one piece that we have some degree of control over. So medication is also something that we need to look at for cognitive impairment. Medication can make your cognitive impairment worse. And so another reason why we may not want to overtreat, right? So if we're improving your tremor, but you are very confused all the time, we have not helped you out. So, and other medications as well. So there might be other medications on board that tend to contribute to confusion as well. So we want to be looking at everything in the whole picture. I think I wrote here again, try to avoid multitasking. And then interacting with groups. I'm sure you probably have all just realized this by living with the disease. It's oftentimes a lot easier to interact socially, one-on-one or in small groups. So I have a lot of patients with Parkinson's that start to feel really isolated because they can't engage with their family and friends in the way that they used to. And they find that they're at a table, a conversation, they're at a dining room table with 10 people, and by the time they try to get a point in, the conversation is like 8 points past the contribution that they had. It's a lot if a conversation is going at the speed of everyone else at the table and your brain is fully capable of participating, but it's just a little bit slower than everybody else's, it can be really easy to start feeling left behind in those situations. and to have that become a reason why you don't want to engage with other people, because that doesn't feel good. So one-on-one or in a small group of people that is cognizant that you're just going to take a little bit longer tends to be a lot more fulfilling ways to interact with other people, where the conversation and activity can move at a pace that you are able to participate in, rather than everyone flying along faster than you can. Okay, so the last thing I wanted to chat about was DBS. We've got all our lovely DBS reps here. Are you guys familiar with DBS at all? Yeah. I haven't actually recently, I love this picture because it's like an X-ray of the leads actually in the brain. So you can get a sense of how big they are. And also, that it doesn't necessarily look exactly the same on both sides. DBS, essentially with DBS, we've kind of split your Parkinson's brain in half. We're controlling one side with one lead and one side with the other lead. And you can see that they're not actually exactly symmetric in this picture here. So if we look at each, it just went away. So we look at each side of your brain as an individual. We're trying to target the specific structure that we're trying to get on each side. You can also see here where that coil is, that these leads are capped. So when the lead is inserted into the brain, there's an extension lead that comes from so this is the lead right here, the slightly larger part of the bottom, about the width of a piece of spaghetti. And then it is capped on the skull, so that thing is not moving. So once it scars down in your brain, it should not be shifting around in your brain at all. So if that cap wasn't there and that lead got jostled, then something could potentially happen. But they are capped into your skull so that if you get in a car accident, let's say, and the extension wire in your neck were to be a problem with that, it were to get stretched or heaven forbid broken, which doesn't happen very often, but that should not affect inside your brain. Oh, was that the cap? I was like, I can tell Taylor's getting at something. That's what you guys want to see. That's what the cap looks like. You can feel it on the skull. So for gents who are bald, you can see it a little bit. You can see it under the skin. There's just a little raised area. Everyone else, it's not going to be obvious. So here's a drawing here. So there's a very small structure that the lead is trying to go into. And then the cap in the skull here, the extension wire, and then it connects to a generator in the chest. So some people have one and some people have two. So you can have a separate generator for each lead, or you can have them both connect to one lead on one side of the chest. Surgeons and neurologists have very different opinions on which ones we like. Surgeons typically like to do them separately, like to do two generators. We love if someone just has one because it's a lot easier to program. And I don't think we can get to this video, unfortunately. But it sounds like you guys are fairly familiar with DBS. So the results can be pretty dramatic in patients. I like to remind folks, if you've seen videos of the very classic off video and then you turn it on and everything stops, that is the result of probably months of programming, at least several sessions of programming. So it's not a magic bullet that we implant the DBS and everything is great. We implant the DBS and then we have to program it appropriately to create the right electrical field in your brain. And that takes a little bit of time. So we hope to get you there if you do end up with the DBS, but it's not an instantaneous fix. It's a process of working with your programmer to get things squared away and to get that stimulation correct for you. But hopefully quicker rather than slower. And for a lot of people, it is quite fast. A lot of folks within a couple of programming sessions, we're in a pretty good spot. So when we're talking about the symptoms that can happen with Parkinson's advancing. So what can happen if we're getting these motor fluctuations, we're getting symptoms like hallucinations and like blood pressure dropping and like dyskinesia, that extra movement, that are made worse by the Parkinson's meds, right? So what are some of our options for people that might be experiencing those problems? They need medication, but if they take their medication, they have 5 other problems that happen. DBS is possibly one of those options in the right person. So what does it help with? So DBS helps with motor control. So DBS is not going to help with, it doesn't on its own, it does not improve hallucinations. It does not improve cognition. It doesn't change your sleep on its own, but it helps with motor symptoms. So it helps with rigidity, tremor, slowness, and smallness of movement, some walking. So there are kind of two components of walking. So with walking, when people have difficulty with walking, some of it is due to the stiffness. So if your ankle is incredibly stiff, you can't go through the heel strike, roll through of a normal gait, right? Because everything is really, really tight. If we can loosen up your ankle by making you less stiff, that can facilitate better walking. But it does not help with the coordination aspect of walking. So your brain trying to figure out the complex motor tasks of how to walk, that is not helped as much by DBS. So we have to be a little careful about recommending it for walking because it's a bit of a mixed bag. It does help with motor fluctuations. So essentially what we're doing with deep brain stimulation is if you're taking meds throughout the day, let's say by the time you might need DBS 5 or 6 times a day, and those meds kick on and then those meds kick off, and the meds kick on and the meds kick off. But there is a period of the day where you're doing pretty well, and it might be really short. It might just be like 20 minutes at a time that you're doing well before the meds go too high, and then as the meds start to wear off, you're doing pretty good again for another 20 minutes. If there's a period where you have pretty good motor control, but you're not staying in it throughout the day, DBS can help get you there. So we're basically providing a more stable baseline that stays consistent 24 hours a day that we can then layer the medication on top of. So that when you're using the medication, you're not, the low that we're dipping down to is no longer as low as it was before. So we've increased your baseline of motor control, and then we're just kind of supplementing with medications. So we have a lot less fluctuating rather than these huge dramatic swings that we can get to with medication alone. That is really where DBS is hugely helpful. If we are able to reduce medications, which we can in most people with DBS, then we can secondarily help with these other symptoms. So if we can reduce medications, we can possibly improve your blood pressure dropping because we're not worsening it with the medications anymore. We can improve dyskinesia, which is potentially a big reason to look at DBS. And then we can also improve fatigue if the medications are causing fatigue. What does it not help with? All the non-motor stuff. So if your primary reason for wanting DBS is because you can't talk very well, this is not going to be a great option for you. So we want to make sure when we're looking at deep brain stimulation that we want you to, if that's the route that we go, we want you to have an excellent response. And so we want to make sure we're picking the right people. It's not to gatekeep this therapy and not let people have access to it. We don't want you to have brain surgery if it's not going to really help you out. And so we want to make sure we're picking the right people. And the right person, it doesn't necessarily have a whole lot to do with like how bad is your Parkinson's per se. It's just what combo of symptoms do you have? Do you have the right combo of symptoms that DBS happens to be a really good treatment option for? So patient selection is something that we really talk about. It's a conversation we have in the office. I always talk to people, what are your goals? If we do this surgery, what are your goals of doing the surgery? What outcome do you hope you'll get from it? And if that outcome is something that I think we can achieve from it, then it's potentially worth moving forward. So who's a good candidate for DBS? So people who are primarily having motor symptoms, not necessarily exclusively, but primarily having motor symptoms, but who are having fluctuations in their control, who are having more off time, so their meds only work for an hour of their 4-hour dosing interval. That's not great. That they're having to fully plan their day of like, I have to take my meds 30 minutes before I go to the grocery store, and then I've got to be back from the grocery store in this amount of time before my meds wear off. That's not great. And so if that type of thing is happening, then this could be a good option. Or troublesome dyskinesia. So if the dyskinesia is bothersome to you, or potentially causing balance problems or significant fatigue, this could be a good option. People that have really bad nausea with the medication or really bad orthostatic hypotension, so that they just really cannot take the meds. They respond to the meds, but they have horrible side effects from the medications. And so the cost-benefit ratio is not falling in their favor with medicines that, we try to give them a little whisper of a dose and they're just hugely nauseous. They just can't tolerate it. Sometimes they're a good candidate for this. And then people without significant cognitive impairment. So a little bit of cognitive impairment is okay, but if folks have evidence on testing of dementia, there's a risk surgery could make that worse, and that's not something that we want to do. So we don't tend to advise it there. Or very uncontrolled depression or anxiety. It's okay to have depression and anxiety as long as you're doing pretty well in terms of managing them. But if people, let's say someone has bipolar disorder and they just had a manic episode 3 months ago, that probably wouldn't be a good person to go for DBS. It doesn't mean with bipolar disorder you can't have DBS. We just want everything to be really well controlled before we go down that route. And then someone who doesn't have medical issues to make surgery really risky. So kind of going without saying, but if you've got really bad heart failure or something like that, that would just make you a bad surgical candidate in general, this probably wouldn't be the right route to go. Typically this is 2 surgeries. So it's generally the big surgery to put everything in your head and then a really short second surgery to get the generator in your chest. Okay, so just a couple other points I want to make and then I will stop talking. But treating Parkinson's is a balancing act. And this is where, as a provider who treats Parkinson's, I really want to partner with you guys. So I can have my agenda of what I think is important, but if that is not what is as important to you, I need to know that. So it's a balancing act between determining what are your priorities, what is affecting your life the most. So some people may say, my priority is to not be tired. I'm so tired during the day. If we need to reduce medication so I'm less tired, I'm okay with that. I'll deal with being stiff. I am so tired. Other people will say, I still want to go hiking every weekend with my dog and my spouse. Like, that moving is the most important thing for me, right? So I want to know what is most important to my patients and also safety risks. That's the big important thing too. So this is all about finding balance. We are unlikely as Parkinson's progresses to gain total control over all symptoms. And so when we're looking at that balance, we're trying to figure out what's most important for your quality of life and for your safety. More meds and more DBS is not necessarily better. These are all things that have side effects. And so we have to weigh all of that when we're looking at treatment. I think we talked about this. Okay, I wanted to just put a touch in for, I know this is Pueblo. You guys live several hours away from Denver. I just wanted to put a plug in for movement disorder specialists. So movement disorder specialists, the vast majority of what they see all day long, every day is Parkinson's disease. They see other movement disorders too, but based on how common Parkinson's is, the vast majority of what they do every day is Parkinson's. And they have extra training in their medical degrees and in their residencies for treating Parkinson's disease. They tend to be the most up to date with clinical research, ongoing trials, things, if anyone's interested in clinical trials, they tend to be the most up to date with that. And they have seen the weird situations. So when you see, the more specialized a doctor becomes, the more and more they only see the weird stuff. And so the benefit to that is if I might see something in my career once and they've seen it 5 times this year already, right? They have more experience in treating it. And so it is always good to get in touch with to establish care with a movement disorder specialist as part of your Parkinson's team. That does not mean you need to see them all the time. So sometimes telehealth is now a tool that we have. It's not the best tool for movement disorders because it's harder to see movement through a telehealth appointment, but sometimes that is an option. Oftentimes with my patients in the springs, I recommend partnering where maybe they alternate between visits or they see the movement disorder specialist once a year and then they see me in between that and we act as a team. So it is good to have the specialist on board if that's something that you can do, either make a trip once a year or do a telehealth appointment. But that can be really helpful just to make sure that there's nothing that's being missed. And as a general neurologist, we don't get our egos involved with that. So if I have patients tell me they would like to see a movement disorder specialist, I am fully supportive of that. And then I just put my role, I will support what that movement disorder specialist recommends. So what you don't want is 2 providers that have different opinions about things and are trying to drag you in 2 different directions. That doesn't work. But so if I have patients that are seeing 2 different neurologists, I will kind of step under the movement disorder specialist and take that route so that we're partnering under the same paradigm of your care. That's what I thought. Thanks for listening. I'm sorry, that was a little long.
Any questions for Beth?
Yeah. Mm-hmm.
Does glaucoma is caused by the medication?
No, but glaucoma could be one of the things that makes hallucinating a little bit more likely, because if it's to the point of affecting your vision, then it could, those like shady spots that you can't see very well that your brain is trying to figure out what's there, that could possibly cause it to put something else there, so essentially create a hallucination, but it is not a side effect of the Parkinson's medicines.
Because on the medications sheet that they're giving us, they say that it can increase the pressure of the blood.
Which medication is it that you're talking about?
Well, mainly the neurodopa.
Okay, that's not something that I've seen, but I can definitely, I can look into that for you. Yeah.
Do you ever treat people that don't take meds for Parkinson's?
Yes. Some people early on can avoid it. So I have, and those are generally people that are really active. So people that have mild symptoms that are very active and are able to maintain that type of exercise schedule. So they go, for a hike or a walk for an hour or two every day type situation. Oftentimes they can prolong the amount of time until they need medication. I also have some patients who are, if I have folks who are quite old and have a lot of other health things going on, and let's say they're already in a wheelchair for other reasons, the likelihood of Parkinson's medicines causing problems versus meaningful benefit in their lives is probably not weighed in the right direction, right? Sometimes those folks I will monitor and not put on medication. Mostly for folks if they're not walking. If folks are walking, typically they significantly benefit from medication. So there are circumstances. Treating Parkinson's is symptomatic. So with Parkinson's, we're not tremendously, with the medications we currently have for Parkinson's, hopefully this will change soon, but with the medications we currently have for Parkinson's, we're not affecting the disease process at all. So the disease is progressing at whatever rate it's going to progress, which in some people is very slow and some people is a little bit faster. And so we're treating it, so when we use medications, we're essentially using it as a Band-Aid to mask symptoms and improve your function. So if people feel like they are functioning fine despite their symptoms, then there's not then we can hold off on medications. What I find though, oftentimes is that folks, because the Parkinson's has progressed relatively slowly, that they've potentially lost track of what normal movement is, because they've maybe not been moving normally for 4 or 5 years. It just kind of very gradually crept up. And so oftentimes folks tell me that they think they're doing okay, but what I'm seeing in clinic would kind of suggest to me otherwise. And if I can convince them to try medicine for a week and just see how they feel, and they say, oh my gosh, I feel so much better, when they didn't realize how stiff they were because it had fully become the norm, right? And it just gradually, so it has nothing to do with being unaware of your body. It's just that your body's norm has changed so slowly that you've lost track of what quote unquote normal is. So most people, I don't think avoiding medication is the goal. I 100% feel like not over medicating is the goal. And I always talk to my patients when we talk about medication changes of what I think the goal would be of making that change, the reason that we're considering making that change, what are potential side effects, and then always having the option of going back to what we were doing before if the goal is not achieved. So medication management with Parkinson's is sort of an ongoing dance. It is maybe frustratingly not something that stays stable over years. Sometimes early on it'll stay stable over a couple of years, but oftentimes we're in this dance of trying to best control symptoms, best avoid side effects. Or let's say we tried to increase it and that was not a good idea, and so then we bring it back down again. So it's sort of a constant change throughout someone's lifetime. There's not a goal thing where when I start treating someone with Parkinson's, I'm not trying to get them to a certain point. I'm trying to help improve function as best we can, and that looks different for different people. So I would not put avoiding medication as a goal, but as the 800th plug for exercise, oftentimes exercise is a good way to delay the need to increase medication. Yeah, and for sure, no question. And I know there are some people that's more practical for than others, but yeah.
I heard an internist say that levodopa carbidopa is a thyroid suppressant.
It's not a powerful one, but it would be a good idea if you have thyroid issues already to check your thyroid level. It's something that we take into account. I have not, in my experience, seen anyone's thyroid level plummet with starting the medication, But for people that are already on thyroid supplementation, certainly if we make changes in their medication level, it'd probably be a good idea to get an updated thyroid test just to make sure that things are okay.
The cognitive issues with DBS, I know we probably discussed this with his next appointment, but when you go in and you are evaluated for DBS, what exactly of the cognitive issues are looked at?
So what we do actually is we send folks to get formal neuropsychological testing. So if you've had cognitive screen in your clinic visit, it's like 10 minutes, a little screen. And that gives us it's a way of us sort of tracking progression, but it's not really a way of diagnosing anything. If we're really trying to evaluate, does someone have dementia or do they appear to be at risk for dementia? We send you to see a neuropsychologist and they do cognitive testing that's like, depends on the person, 4-ish hours long. So it's a process. And they actually give us their recommendation as to how they feel about the prospect of worsening that with DBS. So if folks are in the mild, you guys can speak to what your experience is, but if folks are in the mild cognitive impairment range, typically which is just essentially means there's only problems in like one domain of cognition. So like your short-term memory is terrible, but everything else is okay. Or you've got some mild deficits in a few different areas, but none of them are terrible. That's typically not a red light, but if there's concern that things really are starting to look like dementia, then what we don't want to do is give you brain surgery, which is going to potentially trigger a dramatic worsening of that. So the answer is we follow the recommendations of the neuropsychologist. And we can have conversations with them. If things seem to be like really on the border, we can potentially have conversations about that. But
and memory seems to be like a big part on if everything's kind of mild, but it's spiked a little, like the memory side is lacking a little bit more, then that's where I've seen it get denied more.
So, and it's worth thinking about because, I mean, oftentimes it's an initial thing that like folks will have a little bit of cognitive impairment like after the surgery and it gets better over time, but I have seen that happen. So it's not, I'm a huge proponent of DBS in the right person, but it is brain surgery. And so it's not something to just blow off and not take into consideration. But particularly with Parkinson's, there are so many, it's one of many things. For when we use DBS for essential tremor, I think that's a lot harder thing for folks to deal with that prospect. Like, what if it affects your memory just a little bit? Because they're otherwise functioning totally fine and they just have a terrible tremor and the trade-off maybe doesn't seem adequate. For folks that are really impaired by their motor symptoms with Parkinson's, sometimes folks say, you know, if there's a little bit of a step back, that's an acceptable risk for me. So it's an individual conversation. I will say the folks that I've seen, I programmed people when I first started working in Parkinson's that were in the like very early days of DBS implantation. And so I kind of saw a lot of the worst case scenarios initially. And a lot of that seems to be a lot better now. So I saw you had your hand up, sorry.
Yes, actually, I was going to have partially been evaluated for a deep brain stimulation. And just, do I need to go also to physical therapy to watch how that will work?
Yeah. So how we do that, so the eval, which I didn't put up here, but good question. So the eval for DBS is essentially twofold. So it's the cognitive testing that we send out to a neuropsychologist to do. And then the second part of it is what we call on-off testing. And that's probably what you're talking about. It can be done, at least I do it myself. I'm not sure how every urology group does it, but I do it myself. So we have you come in and so you take your last dose of medication the night before. You don't take any medication the morning of the test. You come in and we do an extensive motor test. So pretty similar to what you have in clinic every time, but maybe about twice as long. And we've got to assign a number to everything. And then we have you take essentially a double dose of your medication, so a really high dose of your medicine. And then about an hour later, we recheck you, and we want to see that there's about a 30% improvement in your movement between those. If we see that, then it's likely DBS will be helpful. What we don't want to see is, let's say you have really bad motor control, and then we test you off of medication, and we test you on medication, and it looks about the same. If that's the case, the stimulator is unlikely to be super helpful. So that's how we do the motor testing. I mean, most of the test itself takes like 15 minutes and 15 minutes, and then you just kind of hang out for about an hour in the middle when you take your meds. So, and I warn folks, I mean, you probably need a ride anyways because you're probably super stiff and shaky when you come in for the testing, and then you might be very dyskinetic when you leave because we have to give you a really big dose to do the second part of the test. So generally want to have someone with you for safety reasons for that. Yeah, but that's the if those two things look okay, then at that point I feel comfortable referring, and we have goals that seem appropriate, right? That what we're hoping to achieve with the stimulator seems reasonable. That's when I would refer someone to a surgeon. We have a surgeon that's a DBS in the Springs, and then there's a lot of surgeons that do it in Denver. So some people will see a movement disorder specialist first, some people won't. We can do programming for DBS in Colorado Springs. I don't know about Pueblo. I think no, but I'm not.
Yes, Dr. Jim.
There we go. So there you can do it here too. So sometimes folks, if they do want to go through movement disorder specialists, will go up to Denver initially, and then either after the DBS is implanted or after the initial programming is done, then they'll return back and have their local neurologist do it, or it can all be handled at the local neurology level.
Well, I've been tested for the site already since March, but I'm having problems with the insurances.
Okay, the insurance bit, they might be able to help a little bit more. That side I unfortunately can't speak to, but it sounds like you've maybe had all the testing done. Yeah.
Except for the physical therapy.
If your insurance is requiring a physical therapy eval, which isn't normal, but that's certainly something that probably you could get a referral for.
Well, they're so slow. That you don't know what to do anymore sometimes because
Yeah.
they just, I mean, since March.
I mean, I'm not plugging for Colorado Springs, it's just the environment I know because that's where I work. We're not looking out as far for physical therapy. We used to be, but I think it's a little bit better. I think it's improving. So maybe if you can't get in here, maybe they can refer you up to the Springs to have a physical therapy eval, maybe. That might be a little faster. It's not great. I mean, access still isn't good, but I don't, it doesn't sound like, I don't think it's that bad. So, yeah, that sounds frustrating.
Yeah, it is.
Yeah.
Any other questions?
How many procedures do you think are done each year? DBS?
Oh, how many are done?
I mean, nationally or?
I don't know.
You'd have to probably ask each of the individual physician, that you might be working with. I think it's a good idea to talk with the surgeon that you might be contemplating having the procedure with and ask them. It's a fair question. They'll be very upfront with you. They're very transparent with, how many they've done, their outcomes. Those are some good questions to ask your physicians.
I'm gonna this is a fully random, just like based on the patients I see, maybe like in the realm of like 5 to 10% of Parkinson's patients, which is total guess. And that probably totally differs from provider to provider in terms of how comfortable they are with DBS and how much of a proponent they are or not of it.
Penetration of DBS nationally, not Colorado, is high single digits, low double digits. Nationally, you would see.
Are they like 1,000?
What's that?
Were you saying like 1,000 patients nationally, or what do you mean by that?
No, I'm talking about the number of patients. Let's take the number of patients that are diagnosed with Parkinson's. That percentage of people that have Parkinson's nationally, say 9 to 10% might have DBS.
Okay.
So I'm trying to be right.
Yeah.
Going back to the issues with the brain, if you have other issues like too much fluid on the brain, would that be an issue that would?
Potentially. That would probably be a really good, that would probably be a decision ultimately the surgeon would have to make. I would say my biggest concern with that is that there is another condition called neurodepressal hydrocephalus, which can look very similar to Parkinson's and does not respond to DBS. And so if there's a concern for people of having both, which can happen, then we would really need to see again with that on-off testing, what improves with DBS and what doesn't, and then whether that's something that a surgeon feels comfortable implanting or not.
And they do typically an MRI before.
Oh yeah, we absolutely have that. Yeah.
So it will be under anesthesia, MRI, that we lay over a CT, and that shows us vascular, it shows us pretty much just anything to look out for, so that the surgeon feels comfortable with it.
You've already had the MRI and that's what showed the excess fluid.
So then
Or whatever it's
we'll
called.
chat about that further.
All right.
What kind of medications are on the horizon?
So, I mean, the one I've been telling everyone about that hopefully will actually get approved next year. There are, I think we are on the verge, if not definitely, we will have essentially levodopa pumps in the very near future. So for those who are familiar with insulin pumps, sort of, or you've heard of the concept of an insulin pump, kind of a similar concept. So all we have, all that I've been able to find, I won't say that's all that's out there, but I've done a lot of looking. So I think all that's out there is basically the clinical data of what the results of treatment with these pumps are. So I have no idea what they look like. My guess is they'll be on the larger side because historically when we've tried to infuse, find ways of getting levodopa into the system other ways, it's a very big molecule. And so that's partially why we haven't been able to give it other ways that have worked. So we basically have this pill that gets absorbed, peaks, and then drops. And we have a pill that peaks and drops. And this has been the problem with Parkinson's for decades of how do we stabilize this? How do we get this in a way that is consistent throughout the day? And because it's a large molecule, it's hard to do. So I'm guessing the pump is going to be a little on the bigger side to fit the, so that it actually can fit the drug in there, but I'm not positive on that. I could be wrong. So it's going to be a catheter, kind of just like an insulin pump, I'm assuming, that attaches to the body somewhere through a little needle and is basically delivers the drug in small amounts. I don't know how far apart it is. Let's say it's going to be like 2 or 3 minutes apart. It gives a little bit amount of medication, 24 hours a day. So the idea behind this is for people that are having lots of peaking and troughing, that they can get a consistent delivery of medication throughout the day. I think we'll be able to fine tune it a whole lot better. So rather than your option being whole or half pills, and that's kind of the options we've got, right? That we'll be able to fine tune it a little bit better, and 24 hours. So the folks that have issues getting up to go to the bathroom in the middle of the night because they're fully off and they're going to fall, that we can avoid that. So it was there, I think, as there are multiple versions of this that are in the FDA approval process. So I think we're going to have it next year. So that's the thing I'm most excited about, because a lot of this, do your symptoms get worse? Do you get horrible dyskinesia when your medication is peaking too much? Or is your anxiety driven by your drugs dropping 5 times a day? A lot of this, I think we can smooth out a little bit. It's not going to change all of it. It's not going to get rid of everything, but I think it's going to smooth things out a whole lot more. I think it's going to provide a lot better options for people with advanced Parkinson's that fluctuate like crazy. So that's the thing I'm most excited about. But we aren't party to all of the like fun details about what things look like and what the actual treatment plans are going to be until something's actually approved. So we just kind of have the preliminary information, but I think that could be game changing, honestly, for Parkinson's. So it's something I'm really excited about. And not every, you'll have, it's not going to be available to everybody. You're going to have motor fluctuations and things like that, I think, to get it. But I think it's going to be hopefully a really good tool. So that's the one I'm most excited about. Yeah. Is it what?
They didn't do it.
So it's going to be like it'll be like liquid that will be delivered through a needle into the skin. Yeah, yeah.
Because I know they have one that.
Yeah, so similar concept to Duopa. Similar concept, except for it's not going into the GI tract. So for people so you don't have to have a feeding tube to have the medicine. And for people that have GI absorption problems, right? That if they have food in their stomach at the same time they're trying to absorb the meds, everything goes haywire. We're ignoring the GI tract altogether. So my guess is it'll be easier for people with nausea. I think it's potentially going to solve a lot of problems. So, but similar concept. Yeah, yeah. I think a little more user friendly.
Deep brain stimulation, you don't pass all the qualified tests. Do you recommend that?
I think that might be a really good option, yeah, depending on your situation, but yeah. Or as even a first step before we do DBS to see if that solves the problem or not, right? And if it doesn't, then maybe DBS would be an additional option. Yeah. Yeah. So I think we have some new, I think we have some new exciting things on the horizon in the next few years in terms of drug authorizations. Yeah, yeah. So we can never know with the FDA what's going to get approved and what's not, but I think there are some good things coming. So, yeah. Anything else?
Has the FDA been holding back on, because levodopa carbidopa has been out for 60 years.
Yeah, no, it's,
What's been,
so again, it's a large molecule that is difficult to get into the system other ways. So I think it's actually been and don't quote me on this, please, but I think it's been like medical engineering issues, actually, like trying to find a way to deliver it in a way that is better for patients. I think that is, I'm sure that has been the goal of drug development from day one. And it's just been, because what we've had for the last 15, 20 years has really been a lot of other medications to try to solve the problem of motor fluctuations, right? If we could just solve the problem of motor fluctuations, it's a lot simpler. I don't think that's any pharma conspiracy. I think it really is hard to do. Not to get into the weeds, but the drugs that have been approved aren't actually or that are being approved aren't actually carbidopa levodopa. It's actually a precursor that has to be converted to carbidopa levodopa in your body, which then gets converted to dopamine. It's like a two-step dealio. So, and they had to show in the clinical trials that ultimately the levels of dopamine in your body were good, right? So it's a complex bioengineering process. So I think we're probably finally nearing the end of probably a very long process to get here. Yeah. The reason it was one of them was supposed to be approved this year, and there was some problem with the pump. And so that's why there's a holdup, unfortunately. So I don't know what the problem was. So hopefully next year.